Good afternoon, everyone, and welcome to today's presentation. My name is Dr. Astral Webb, and I am the Director for the National Center for Health and Aging. I want to welcome all of you today. For those of you on the East Coast, pleasant good afternoon. To those of you on the West Coast, pleasant good morning. Our topic today for today's discussion is on HIV and AIDS, and it's particularly addressing HIV-AIDS in the elderly population. We have a wonderful distinguished panelist who is going to provide you with expertise information today. We will start first with Dr. Henry Pacheco, who is the Director of Medicine and Public Health at the National Hispanic Council on Aging. He will be followed by Dr. Harvey Makadon, who is a clinical professor of medicine at Harvard Medical School and director of the National LGBT Health Education Center at the Fenway Institute, which is a division of Fenway Health Boston. And our third panelist would be Danielle Nelson, who is the Aging Services Program Specialist with the Administration on Aging at the Administration for Community Living. We are truly delighted to have all of our guest speakers today as they will highlight some very key issues in dealing with HIV/AIDS in the aging community. So our presenters today will focus on stigma and discrimination among HIV/AIDS aging patients. They will highlight some available resources in the community for aging LGBT patients. They will also share some opportunities to seek funding for health services for HIV patients who are over the age of 50. We can discuss a little bit about the HIV epidemic in patients over 50, talk about some of the sexual risk factors for adults 50 and older, and discuss some barriers that prevent healthcare providers like yourself from recognizing and treating older adults living with HIV/AIDS. So again, I would like to welcome and thank officially all of our panelists for today's discussion, and I would like now to turn it over to Dr. Henry Pacheco. And I will ask if everyone can please hold their questions to the end of the presentation, and we will have all of our speakers address the questions at the same and during one time. Thank you. Dr. Pacheco, welcome, and thank you.
Yes, indeed. Thank you so much. I hope you can hear me well. Well, once again, it's a pleasure to participate in the program. I'm with a great company. Let me go ahead and start very quickly on, since we do have limited time on such a significant topic. So I will be speaking about HIV/AIDS in older adults. I'll briefly review the aging trends in the U.S., likewise a brief overview of the epidemic in the country, and of course, some sexual and other HIV risk factors for older adults, since that's our focus of this webinar. And we'll try to explore and a little bit understand some of the barriers that present clinicians, healthcare providers from recognizing HIV and treating it in older adults. And lastly, the role of the stigma and discrimination, a very important issue as it relates to HIV. Let me go ahead and start briefly with the episode, a profile of the older population in the nation, as mostly a glimpse into the trends of how the population in the U.S. is succeeding. As we can see, persons 65 and older represent 13% of the population in 2010, and this is going to grow significantly. By 2020, there's going to be a 36% increase, and essentially same thing in the older population, those of 85 and above. As a result, in 2030, for example, this population of 65 and older will represent practically 20% of our population, which represents a significant challenge for clinicians, healthcare providers, to start understanding more the clinical aspects of aging. And of course, this will be further complicated by the fact that along with this population, we're also seeing the aging of the HIV population, bringing with itself more clinical and social challenges to clinicians. Of course, all of these is a result of the aging of the baby boom population. As you can see in this graph, there is this dramatic curve in the growth of the over 65 population, and I won't get into the numbers, but you can see the curve is very upward, very dramatic. This slide will serve as an introduction to briefly to the 2 decades of HIV/AIDS. We're actually in our 3rd decade, and as you can see, early in the epidemic, from the 1980s and 1990s, we saw a very dramatic increase in people being diagnosed with HIV/AIDS. Likewise, also very dramatic number of deaths. It was a dramatic decades to live, horrible decades to live, because we just saw a lot of our loved ones die of a disease that was basically unknown. And likewise, the prevalence started gradually increasing. That's the line in yellow. Now, in the 1990s, due to significant efforts in the development of new therapies, such as highly active antiretroviral therapy, and significant efforts in the area of prevention, we saw a very dramatic drop, first of all, in new people being diagnosed with HIV/AIDS. And likewise, and perhaps just as, perhaps even more important, we saw a dramatic drop in the deaths related to HIV. This is one of the successes of the campaign against this epidemic. But as we can see, deaths not only dropped, but did drop, but there's been a plateau a plateau mostly in the diagnosis of people with HIV, and I'll explore that a little bit later. And of course, that explains why, in some ways, the prevalence is growing. In any case, currently, the epidemic in the U.S., just a snapshot, we can see that annually there's anywhere from 48 to 50,000 new infections. That number has really not dropped significantly in the past few decades, and that is something where we need to work desperately, because new infections are feeding into the pool of this existing 1 million people living with HIV currently in the country. One dramatic figure that, of course, I will be highlighting is that of those that are infected in the country, we estimate that anywhere from 15 to 20% are infected but don't know it. That means these folks are continuing to infect others unknowingly. Likewise, of those people diagnosed with HIV care, almost 50% are not in care. So that means that these folks have already been diagnosed. They know it, and their health service knows it, that they are infected, but they're not in care, and therefore they're not benefiting from the significant improvement in HIV therapies, and they may also be infecting others unknowingly because they're not being exposed to prevention messages. In essence, we can say that the HIV epidemic has evolved from an acute disease into a chronic disease. This is due, of course, to the success of treatments and prevention efforts. In some ways, we can really consider AIDS now a complication of HIV, and hopefully in the near future, clinicians won't even see AIDS, because under the ideal conditions of well-controlled HIV patient, well-treated, well-managed, AIDS should not be developing. This slide briefly describes that unfortunately HIV is not affecting everyone equally. It tends to hit harder the underserved, impoverished populations in the U.S., the African American population, Latino population. And of course, that's in terms of race and ethnicity, but in terms of infection, it's still a significant health burden to folks that, to men having sex with men, where you see that the greatest impact of the epidemic, and also significantly in heterosexual contact among females and males. And we should not discount, of course, the role that injection drug use has played in the fueling of the epidemic. And this tells you the vulnerable populations that are still are a significant challenge in the management of this disease. So HIV in older adults, we have that it is something that is alerting everyone. There's a Senate committee meeting about it. And essentially the problem is that by 2050, which is around the corner, 2015, which is around the corner, half of the population living with HIV will be 50, which means 50 and over, which means that clinicians have to have two challenges. One, having to deal with aging population and all those diseases associated with aging, the chronic diseases. But now you will be having a disease that to many of them is a new disease to deal with in an older population. And of course, preventing the spread of HIV among this population also poses many great problems and challenges. as the square shows in the left-hand side, many of these older adult folks are just not practicing safe sex. They're not well informed, and they're just not helping in terms of preventing the spread of HIV because of various factors that I'll explore. In essence, it's the fastest growing HIV population. As you can see, the percentage of older adults with HIV, for example, from 2001 to 2005 grew by 77%. So this is a significant condition and significant circumstances that healthcare providers and health and service providers will be facing. Why is HIV growing among older adults? Well, there's several reasons, but one of the reasons, of course, the improved survival of people with HIV due to the success of highly active antiretroviral therapy and prevention efforts. More and more people who were infected in their 20s and 30s are now surviving and living into their old age. In those who are in treatment, of course, are living into their old age in relatively good health compared to, a decade or two ago. Second, large numbers of older adults are becoming infected with HIV annually. Dr. Makadon will show the actual increase in this population, that the contribution to the fueling the epidemic, that almost 10% of newly infected people are older adults. And second, why is it growing? Well, because the presence of multiple and significant risk factors that places older adults at risk for HIV. This is an exploration of some of the risk factors that we have here in terms of HIV risk factors for older age. One of the main things is the lack of awareness of HIV risk factors. A lot of the messages for HIV have been developed towards younger audiences, younger populations. As a result of it, the older folks, older adults, do not see themselves at risk of HIV, and they perceive this to be a disease of the young. And so the studies have shown they are really least likely to practice safe sex, unprotected intercourse. And of course, we have to highlight that older adults are also not free from drugs of abuse and alcohol, which in many cases fuels irresponsible behaviors. So in addition, when older adults go to their physicians for their regular care, for their diabetes, hypertension, and other issues, we find that primary care providers are really not considering their older adult patients at risk for HIV. They're not given the prevention messages, and they're not taking adequate sexual and drug use histories, simply because they don't consider them as vulnerable to HIV. Secondly, we've seen, of course, the introduction of new medications, new drugs such as Viagra, which have extended the sexual vitality of older adults. And as a result, we've seen a lot of significant rates of no testing in this older population, lack of HIV testing, or late testing. And late testing, of course, means that the virus has had a greater opportunity to do even more damage to the immune system and to other organs. Primary care providers are simply not following the recommendations of the CDC, which recommend, of course, testing annually as part of their regular health care, all individuals between the age of 13 and 64, and everybody over that age who falls into the high risk factors as outlined earlier. So as a result, HIV test is not yet a routine test like cholesterol, like glucose, for in healthcare settings. That's something that healthcare providers will have to remedy. As far as women is concerned, well, older adult women, as they are now free from risk of pregnancy, well, they don't see the need for condoms. Condoms has been associated in their generation as a prevention for pregnancy, as a prevention of sexually transmitted diseases, and since they feel that they are free from both, then they're less likely to use it. Secondly, we know physiological there are many changes, and one of them is, of course, important, that the vaginal mucosa in postmenopausal movement is thinner, and it becomes more easily injured during sexual intercourse, and thus making it easier for the HIV virus to infect women. So why is HIV not recognized in older patients? Why is it that primary care providers are just not recognizing? There's several reasons. One of them is the stereotype that older adults are just not sexually active. And so that sexuality is not being considered in the history taking of the patient. There's no limited or no sexual history and no inquiries about drugs of abuse among older adults by primary care providers. They're considered safe in their monogamous relationships and simply not at risk of HIV or sexually transmitted diseases. Many clinicians simply consider that the heterosexual relationships of their patients free them from this risk, and they're unaware that, of course, that many of their patients are potentially involved in high-risk sexual lifestyles. In addition, well, in essence, there's a low index of suspicion and, of course, low rates of HIV testing. Another significant challenge, of course, is that many of the symptoms associated with HIV are also similar to those symptoms related to aging: fatigue, wasting, loss of muscle mass, some cognition difficulties. These are very similar to issues that you see in aging, and so they could be easily overlooked. Challenges. Well, the older HIV patient represents challenges to primary care providers. Lots of comorbidities are common. Primary healthcare providers will have to learn a new specialty drastically, new medications, side effects of antiretroviral regimens, side effects in older patients. They have to, in their differential diagnosis, they have to include the symptoms and question themselves: are these symptoms related to aging? Are these symptoms the effects of HIV virus? And are these symptoms related to the effects of the medications, the antiretrovirals? Those are challenges that for primary care providers. And of course, the importance of adherence and continuity of care, and I believe Dr. Makadon will be expanding on this issue. Adherence and continuity of care are of greatest importance in the management of HIV, as it might be in others, but it's crucial in HIV due to the development of potential, potential resistance to medications that can occur if care is not adhered to and is not continuous. Lastly, very importantly, we have to understand the stigma. I'm going to go in a little bit more detail later on, but stigma is something that has to be included as a very important factor in fueling the epidemic. Lastly, of course, older patients, as folks get older, they experience more poverty, more social isolation, more disabilities, thus complicating the management of HIV among these patients. But in general, we find that more people with HIV are dying of non-AIDS causes, which means that in many cases, HIV has been well managed, and people with HIV are now succumbing to diseases of older age. And of course, the good news is that people are getting to older ages. The bad news is that it represents, of course, a significant challenge to primary care providers. But of course, many of the challenges are definitely not clinical. The care of the HIV requires perhaps more provider, more staff time. It requires a team approach. HIV is really a complex disease which can be costly, so healthcare providers have to be mindful of allocating resources and to care for HIV patients, and it's simply a matter of organizing your practice. And of course, some perceive that clinician productivity is slow, but if you manage this in a team care approach, a lot of these issues can be easily overcome. In general, HIV patients require more support services, or as many support services as patients with other chronic diseases. And of course, some of these are difficult to arrange for. And lastly, of course, very importantly, that many of these patients are minority, non-English speaking patients, and therefore care has to be provided in a cultural and linguistic competent manner. The stigma is a major barrier to the control of the epidemic. As you can see, not only is the stigma there associated with the disease, but also stigma is associated with aging, it's associated with some sexual minorities, associated with substance abuse. What is a stigma? Well, we could say that it's simply a stigma can be defined as shame or disgrace that's attached to something regarded as socially unacceptable, and that is something that we have to fight. Again, some of the factors that lead to stigma and discrimination, well, that HIV is often associated with injected drug use, homosexuality, which is still not accepted by many in our community. HIV is still a fear disease, and there are a lot of myths, there are a lot of taboos around it. And the belief there is also that HIV can be contacted via casual contact. A lot of lack of information still, and the belief that having HIV is somehow a moral failure. Now, I have very quickly covered this very important topic, but I just want to say that an increasing number of primary care providers will be expected to care for people with living with HIV, and that HIV is already a chronic disease, and it should be treated like diabetes, hypertension, and others by primary care providers. And this is something that it will be even more present in their patient population. But I just want to highlight that there are lots of resources for training. One valuable resource is that of the HRSA, Health Resource Service Administration HIV/AIDS Bureau, has the HRSA AIDS Education Training Center. I have the web address there. If you go into the web address, you can see all the national centers and how they can provide training and learning opportunities for primary care providers. There are also the regional HIV AET centers that you can access in every state, every locality in the U.S. to further education, further your training. I just briefly attached there a current review of HIV and aging that you can download. It's online, and it could be a starting point to enter this issue of aging and HIV. But I've exceeded my time by a few minutes. I just want to thank you so much, and I'm going to hand this over to Dr. Makadon, who will be expanding on these issues and covering others that I have not. Thank you so much.
Good afternoon, everyone. Thank you very much, Henry, for the introduction to the topic that we're talking about today. I think there'll be, I'll probably emphasize a few of the things that you talked about. But really my focus is really to talk about HIV/AIDS in the elderly, focusing on LGBT individuals from our perspective at the National LGBT Health Education Center. I do think that Henry's point about what we think about when we think about the elderly is important, and that generally when we think about people, we tend to think about frailty, disability, illness, but don't think about people being sexually active, which is probably one of the most important issues that we need to keep in mind as we begin to address HIV in the elderly, which has been very much under taught in both in medical schools as well as nursing schools and as well as among clinicians over the past few decades. But when we think about elderly people, we have to recognize that we might think about them as eldersexuals. So that when we look at this data from a study by Lindau that was published in the New England Journal of Medicine in 2009, and we look at people ages 57 to 64, 84% of men and 62% of women were still having sexual relations. The numbers decrease somewhat, but are still considerable among those 65 to 74, where the numbers are 67% and 40%. And then again, 75 to 85-year-olds are still very sexually active, with 38% of men and 16% of women. So that we do have to think about this whenever we see our patients, and not only overcome the issue about talking to people about same-sex relationships, and talking to them about sexual orientation and gender identity, but also talking to them about the nature of their sexual relationships and how to, certainly suggesting that they be HIV tested, but also how to protect themselves from becoming HIV infected if they're not already, and then what to do with people who already are. If we look at the HIV incidence by age in the United States, we see that in the CDC data that was released about a year ago, 11% of the people with HIV in the United States were 50 years of age or older. That's a considerable number when you think about the realm of people with HIV, but it's actually of greater significance when we look at the projections for the future, where by 2017 it's projected that 50% of people living with HIV in the United States are going to be over 50 years of age. So that for clinicians, no matter where they are, seeing people who are older adults, and some might call themselves middle-aged adults who are in their 50s or early 60s, we have to think about HIV and talking to people about how to prevent HIV, how to get people HIV tested, and continue to discuss prevention with those who are negative and get people into care who are positive. If we look at when people are diagnosed, it's interesting that among elderly people or among people 60 years and older, that 55% of individuals were when they received their HIV diagnosis already concurrently had AIDS. So that clearly the older people get, as you look at this graph, you can see that people have a concurrent AIDS diagnosis at the time they were HIV tested, increasingly with age, which suggests that people are not getting tested in a timely way, and there's a large delay allowing them to be tested at a point when they probably are already being adversely affected by the HIV virus, making it more difficult to treat them and restore them fully to health so that they can live healthy lives for as long as they might have, even if they had not been infected with HIV. It's also interesting to look at this data from the United Kingdom, which shows that new HIV diagnoses continue to increase in individuals over 50. And this data shows the decade from 2001 to 2010, with the numbers basically doubling over that period of time. Again, the majority of these people who were diagnosed with HIV were diagnosed late. That is to say, they had a CD4 count of less than 350 within 3 months of diagnosis. So that not only are cases increasing, but we're not testing people on time. And I think that there's a huge opportunity for clinicians to do a better job with their elderly patients if they think about HIV as a issue that needs to be dealt with, and get people tested and treated and counseled appropriately. So how do we begin to overcome some of the barriers that lead to this increased number of HIV cases, as well as the late diagnosis among the elderly? I've already talked about the fact that first we have to think about older people as being sexual people and therefore at risk for HIV. But there are also other issues, particularly when we're thinking about dealing with people who may be sexual or gender minorities. So first, I think we should be thinking about ending invisibility of LGBT people in healthcare in general, but certainly also among older individuals. We should be thinking about how to overcome barriers to care and treatment as prevention. And then finally look at effective focused prevention among LGBT elders, because if you think about the prevention information that you've seen, I guess I'd ask how many people really see information which is particularly focused on issues related to elders and which would be of interest to elders when they see it in their doctor's office or in the newspaper, and we have to think about how to target campaigns for people who are at risk for HIV, and obviously elders are one group that need to be considered. So first, with respect to ending LGBT invisibility, I guess I would just ask, and we're not going to do an audience response on this, but ask how many people really have had a sexual history discussed when they are elders seeing a clinician. I guess I would, if I were asking you all, I'd say how many of you over 50 have had a clinician talk to you about your recent sexual history, but even in general, how many people have ever had a sexual history taken, because it's something that clinicians tend not to do on a regular basis. And then more specifically, how often are patients or clients asked about sexual orientation, that is to say whether they're lesbian, gay, or bisexual, and how often are clients asked about gender identity, or whether they're transgender, genderqueer, or have questions about their gender. These tend to be issues which have generally been resolved by the time people are over 50, but that's not always the case, and it's important for us to understand issues related to our patients. There certainly will be patients who will be coming who are older than 50, who are already declared themselves and acted upon being transgender. And for clinicians, it's very important that we understand them so that we can give them appropriate care. But this is a question that's rarely asked in clinical practice, and it's something that we need to be more attentive to and focused on if we're going to take good care of transgender individuals. I think a recent study, which is very interesting in light of common perceptions, is who identifies as lesbian, gay, bisexual, or transgender. This slide actually shows the results of a telephone survey that was done by the Gallup polling organization in conjunction with the Williams Institute, and showed a random sample of over 120,000 adults aged 18 and older in all 50 states, selected by random digit dialing, and asked people whether they identified as lesbian, gay, bisexual, or transgender. On average, about 3.4% of individuals identified as LGBT. But of interest in this study was that while this was more true in younger people than older people, that Asian, Hispanic, and Black individuals tended to respond more positively, especially if they were younger, than white individuals, which goes counter to our general thinking about people's identification as LGBT. If you look at people 65 or older, it's interesting that among Asian and Black individuals, 5.2% and 4.1% of people on this random survey identified as LGBT. So this was above the average for these two important groups, and suggests that we really can't make any assumptions about people when they come to see us, and we have to take appropriate history, including a history of sexual orientation and gender identity in all of our patients, and then follow up appropriately, and in this case think about, not just think about, but ensure that everybody have appropriate HIV testing and counseling, and follow up with linkage to care for people who are positive, and continued counseling and discussion about behavior change for those who are negative. In terms of LGBT elders, 1 to 2 million LGBT elders live in the United States now, it's anticipated, as Henry suggested in his study, in his slides, showing the growth in the elderly population, that the number of LGBT elders would be twice what it is now by 2030. Another study by the Williams Institute showed that among same-sex couples in Ohio, 20% were 55 years or older, and 5.4% were over 65. It's also important and of interest in terms of making sure that people get appropriate care and follow-up, that LGBT elders are more likely to live alone. The BRFSS survey showed that 49% of gays and lesbians 50 years or older or more lived alone versus 33% of heterosexuals 50 years or more. So there's a really considerable increase of people living alone and having lack of home support for a variety of things, including taking good care of themselves, taking medications, and making sure that they're eating well and active. I wanted to turn a bit to the test and treatment cascade, which, again, Henry alluded to the elements of this, but demonstrate that if we look at the United States as a whole, and this is not just elderly people, but all people, we have about 1.2 million people in the United States who are infected with HIV. But at every step along this cascade, we see a drop-off, so that we see that, again, about 20% of those who are infected have never been diagnosed or still untested. And of those who have been diagnosed with HIV, there's still a smaller number, from 940,000 down to 725,000, who have not been linked to care. And then again, we have a drop-off of people who are linked in care to people who are actually continue to get care and are on antiretroviral therapy, down to 426,000. Perhaps of greatest significance, though, both with respect to individuals staying healthy themselves, but also helping to eliminate the risk of their transmitting HIV to others, is that of the 941,000 people who were diagnosed with HIV, only 328,000 individuals had suppressed viral loads, which would indicate that there was a high likelihood that even if they had unsafe sexual practices, they would not transmit HIV to other people. This is 28% of the population of people estimated to be HIV infected in the United States. So clearly we have a lot of work to do in terms of optimizing both the diagnosis of HIV, linkage and retention in care, and not only putting people on treatment or getting people to take antiretroviral therapy, but ensuring that that therapy is effective, means that people need to be followed very closely and cared for in a way that we ensure that they are really optimizing their treatment. Some of the barriers to routine HIV testing are that it's not being done in some situations. So 50% of emergency departments are aware of the CDC guidelines, which suggest that people should be routinely tested, but only 56% were offered HIV testing in emergency departments in a study in 2011. And only 61% of general internists offer HIV testing regardless of risk. Now, obviously, some people may not be taking a history which really gets a history of risk. Some people make assumptions about people and decide to test some people and not others. But I think this data suggests that everybody needs to be HIV tested at least once in some healthcare setting. and then we can make determinations once they've had a history taken about how often they need to be tested. Certainly some of the barrier of linkage to care has to do with the fact that counseling and testing is often separate from care and treatment, and that we have to think about, particularly in our community health centers, how we can consolidate all of these services so that once somebody has tested positive, they're automatically linked to care and treatment. I think one question that's come up recently has been home testing and what people are doing who test positive in the privacy of their home now that home testing has been made available, and we really don't know that much about that. Certainly once someone has been tested positive, it's important that they be linked to care, and as I said, counseling and testing should be integrated with HIV care. But we also have to recognize the socioeconomic and cultural factors impeding HIV care, which must be addressed. Certainly, my hope is that under healthcare reform and implementation of healthcare reform, that states take advantage of being able to expand Medicaid to all individuals, not just the current categories, because a lot of single individuals are not eligible for Medicaid no matter what their income status. And if states take advantage of increasing their Medicaid coverage to all individuals up to 133% of the poverty level, regardless of any kind of history of being in one of the Medicaid eligible categories, would be eligible for care and make it easier to access HIV care in the future. In terms of resources for prevention, we have another barrier. Federal funding for HIV prevention has not changed since 1991, adjusting for inflation. But at this point in time, it's important that we recognize that men who have sex with men of all ages account for 61% of new infections, but receive only 27% of education and risk reduction funding and 10% of counseling, testing, and referral funding based on CDC data from 2011. Clearly, if we're going to do a better job in this population of people where there has been a rapid increase in HIV, we need to adjust the allocation of funding and target funding for at-risk populations. Clearly, the population that's at greatest risk are young black men who have sex with men, but also the elderly are a group where HIV continues to be an ongoing problem. But as I said before, we have to think about focusing prevention on older adults. And here are examples of some campaigns from Gay Men's Health Crisis in New York, HIV Affects Us All, and trying to demonstrate that we really need to be looking at all age groups, even those over 50, need to know their HIV status and get HIV tested. Finally, I just want to point out that for older LGBT people, there's somewhat unequal treatment with respect to the Social Security system. Social Security represents more than half of the annual income for 2/3 of retirees in the United States. But same-sex couples are not eligible for a lot of survival benefits or spousal benefits that Social Security would often cover. And surviving same-sex partners are significantly disadvantaged financially, making it harder to age in place or stay at home as they age. So this is a compounding of both less revenue or income, as well as living alone and not having family members who might help take care of them. This is more graphically demonstrated on the next slide, where the monthly Social Security benefit is demonstrated for a individual and also shows the benefit if they were able to legally marry, so that because people can't legally marry, their Social Security benefits are restricted. And with respect to Social Security survival benefits, if an individual, if a gay individual dies, his current benefit would be $303 a month, but the benefit if they were able to legally marry would be $1,527 a month. So this compounds, I think, the difficulty people have living with HIV, and is something for us to be thinking about as we think about trying to create societal change which looks at health equity and social equity across individuals. I think there's no question that quality senior care for LGBT seniors involves both cultural and clinical competence, and that we have to think about how we train not only health professional students, but generations of practicing clinicians if we're going to turn around the health of LGBT elders, certainly with respect to HIV, but also with respect to other health disparities that we've discussed in other webinars. That's the end of what I'm going to be saying, and I think at the end of this session we'll have time for questions. So thank you very much.
Good afternoon. Thank you for having me as a panelist on today's webinar. The Administration on Aging, which is where I work, believes that this is an important topic. In 2009, people aged 50 and older accounted for 23% of AIDS diagnosis in the U.S. Yet older adults are commonly overlooked in this ongoing conversation. So the Administration on Aging, which I'll refer to now as AOA to save us a little time here, began to acknowledge that this population needed some resources. And so to acknowledge the 30th anniversary of AIDS, AOA began a campaign focused primarily on prevention. We created an older adults and HIV-AIDS website to help disseminate information. And in 2012, we decided to focus on prevention and assist the aging service providers with a toolkit to assist them in their work with older adults. And very exciting, in September, just this September, we issued $8.45 million in grant funding for the management of chronic conditions, including HIV. The grants were for empowering older adults and adults with disabilities through chronic disease self-management education programs. Of the 22 states who just received this funding, 5 have chosen to implement the positive self-management program. And so only 3% of healthcare spending goes to public health prevention programs. And research shows that community prevention can save 4.5 million lives and a lot of money. It's predicted $600 billion over 25 years. So the the Prevention of Public Health Fund, which was created in 2010 by the Affordable Care Act, is how we came about with this funding. So the PPHF funding gave us the money which we awarded to 22 states. So each state got anywhere between $200,000 and $575,000 each year for 3 years. And the Positive Self-Management Program is one of the 10 chronic disease self-management education programs that the states could choose to use this funding on. 5 of the 22 states chose to implement the Positive Self-Management Program. Those states are Colorado, Georgia, Kentucky, Massachusetts, and New York. And I've included on the slide here the link to the points of contact for each of these awards in the 22 states, in case anybody would like to follow up on a certain state. And so the Positive Self-Management Program, I'm sure many people on this call are already familiar with it. It's a workshop for people with HIV that's given 2.5 hours once a week for 7 weeks. And it's given in community settings. These can be senior centers, churches, libraries, or hospitals. Workshops are facilitated by 2 trained leaders, one or both of whom is a non-healthcare professional living with HIV. And the Positive Self-Management Program is available in English, Spanish, and Japanese. There are several subjects that are covered, and I won't go through those because of time. But what makes this program effective is the process in which it's taught. Classes are very participatory, and there's mutual support and success that build upon the participants confidence in their ability to manage their own health and maintain active and fulfilling lives. And the program doesn't conflict with any of their existing programs or treatment. It's just designed to enhance their regular treatment and HIV-specific education. And I'd quickly like to go over now another area that the Administration on Aging is working on in terms of HIV and aging, and that's the toolkit that we designed that just came out in 2012. And it was developed for states, area agencies on aging, tribal organizations, senior centers, and other local service providers. And the toolkit has helpful resources and materials, and you can access it by going to AOA.gov. And then you see the button here. That's you click on that on the right-hand side of the AOA homepage, and that will take you right to the toolkit. And there is a video that introduces the toolkit that has a message, a 90-second message by the Assistant Secretary for Aging, Kathy Greenlee. And again, you can access the toolkit or go directly to YouTube to watch the video through this link. And then there's a fact sheet that's also available. In the fact sheet, it's titled HIV Know the Risks, Get the Facts. And it's just a simple resource that's made available, we hope, in senior centers and libraries and doctors' offices through our network. And we really are encouraging the Aging Services Network just to print some copies, and whenever they're hosting an educational event, whether it's blood pressure screenings or even senior center meal programs, just to make them available for participants to take home. There's also a customizable PowerPoint that communities can use and include a few of these slides when they're giving other health community presentations. And then there's also the Toolkit poster series, which are great to put up anywhere in the local community, doctors' offices, pharmacies, you name it. And it just helps to bring awareness to the topic and get seniors conversating about the issue that HIV affects all, including older adults. And then there's a great video. It's 5 minutes long. It's an educational video from the toolkit, and it's a resource with a variety of possible uses. And we've encouraged the network to, when holding discussion groups, webinars, health fairs, informational sessions, it's great to incorporate this video to get the topic out there. And then lastly, there's a toolkit promotional info sheet, and it's just a quick tool to help people interested in using the toolkit to be aware of different aspects and how they can use it. And then I've included some resources that are helpful for the network, including the AOA Older Adults and HIV-AIDS webpage, which is the first link there, if you're interested in any additional resources we have linked. And I'd like to turn it over now to Dr. Webb in case there are any questions.
Thank you, everyone. We are going to just take any questions that any of you have. We are going to ask if you can insert your questions in the chat feature, and then we will be able to answer them, get the questions on to our panelists for a discussion. Devin, can we are there any questions can you see in the queue right now? And again, if you are dialed through your phone and you would verbally like to ask a question, feel free to use the raise hand icon that's on your control panel, and your line will be unmuted. Thank you. Okay, we do have one of the questions are, and Dr. Makadon, this is directed towards you. Are there any resources to guide clinicians or health center staff on how to ask appropriate questions for their LGBT patients?
Yes, there are. I mean, I think there are on the website for the National LGBT Health Education Center, which are on my slides, but www.lgbthealtheducation.org. We actually have two monographs called Why Gather Data on Sexual Orientation and Gender Identity in Clinical Settings and How to Do That. And we have a second one on health disparities and overcoming health disparities, which describe sort of similar issues with respect to how you really incorporate a lot of this into clinical settings. It's not all just an issue of the doctor taking a history or the nurse taking a history. Some of this information now can be collected at registration. And in fact, there are some studies which suggest that patients would prefer to put information into a electronic health record on their own rather than being asked this information. Obviously, it's important for clinicians to follow up and discuss the information that people have put into the electronic health record. But there are a number of guidance, and the Institute of Medicine recently had a full-day workshop on this session, the report of which will be out sometime in December, and which again will talk about ways to do this. I think there's a number of other resources, but in the interest of time, I just suggest that anyone who would be interested in this could email me at the National Center, and I'd be happy to get back to you with information about resources on this.
Excellent. Thank you. The next question we're going to open up for all the panelists to comment. Are there any foreseeable changes to the recommendation for providers to test adults who are 65 and over plus who are HIV? So I will repeat the question again. Are there any foreseeable changes to the recommendation for providers to test adults who are 65 plus for HIV?
Well, let me just give this, Harvey Pacheco from National Hispanic Council on Aging, let me just give this a shot, and I'll ask Dr. Makadon or anybody else to pitch in. But, you know, if they're 65 or over, and now I'm assuming that that they mean that don't know their diagnosis, right? Because if they're HIV, they're
Correct.
already HIV positive. If they don't know their diagnosis, well, you know, Dr. Makadon mentioned that these are recommendations, and if the clinicians, through their history taking, sexual orientation taking, the substance abuse taking, they decide that this individual should be tested, it's left up to them. It's not a rule. It's a recommendation. And so, therefore, a lot of this is left up to the index of suspicion of clinicians and simply, you know, good common sense. I wonder, Dr. Makadon, if you have any other views on this.
No, I mean, I agree. I think, though, that all patients should probably be tested once, and then after discussion with their clinician, make a determination about whether they were involved in behavior that would continue to put them at risk for HIV, and have ongoing testing on a every 6-month or yearly basis. But that, you know, we really make too many assumptions about people, and a lot of people actually have a hard time being very forthcoming about intimate information. So I do think it's probably worth making sure that people get tested at least once.
Okay. And this is Danielle Nelson from the Administration on Aging. We did work with the Center for Disease Control when we were designing and producing the toolkit, and we did have a discussion about their current recommendation that goes up to age 64. And so there have been conversations with the Center for Disease Control, and we will continue to have those. So we are aware of that that recommendation cap, and we do believe that, you know, we serve the population of older adults, and they should be included in that conversation. So hopefully stay tuned.
Okay, great, thank you. So the next question is a lead to that one. How do you feel this will impact long-term care in nursing homes?
Well, let me just give once again a crack of that, and of course, Ms. Nelson, Dr. Makadon can pitch in. Overall, the aging of the U.S. population is a significant challenge. Being in a nursing home represents another challenge as to how you can reach them. How can you prepare clinicians in nursing homes? Clinicians, as it is in nursing homes, are already burdened by having to deal with diabetes, cardiovascular disease, even Alzheimer's. So now you have added this new ingredient. I think the integrating of and the coordination of healthcare systems beyond just the clinical hospital setting will go forwards to reduce the overwhelming burden of caring for these multiple comorbidities among healthcare providers. But it just points out to the fact that all primary healthcare providers should have should start pursuing a reasonably good education in the management of people with HIV.
Mm-hmm.
Go ahead.
I mean, I would agree with Henry. I mean, I spent most of my life working in a acute care hospital, not a long-term care facility, where people with HIV and care of people with HIV was integrated into the general hospital population, both in the outpatient and the inpatient areas. And I work in a community health center now, that's the case. I think that we really need to get used to caring for multiple issues, but that in all honesty, once someone with HIV has been diagnosed and put on treatment, probably their ongoing care is in many ways simpler than managing a diabetic patient who will have multiple other complications. There are some patients who will have complications, but if people are well managed, they can live long, healthy lives, and it's really an issue of checking for toxicity to medications, and adherence to medications are probably the primary issues that are going to come up. One of the most concerning things, though, is that there has been discrimination in long-term care facilities in which same-sex couples have not been admitted to assisted living facilities, and gay and lesbian, transgender, bisexual individuals have often not been accepted into nursing homes. And I think that the non-discrimination clauses, the non-discrimination rules, which have been promulgated by the Department of Health and Human Services, will help us go a long way to making sure that we can provide equitable care, assuming that clinicians are also learning about the needs of LGBT people in long-term care facilities.
Mm-hmm. Thank you. The next question is, will AOA consider extending the positive programs in additional states in the future?
This is Danielle Nelson, and I can say that we have formula funding that goes directly to the states, and it's for disease prevention, health promotion. It's Older Americans Act, Title 3D is the formal term for it, and states have the ability to use, states and area agencies on aging that get this funding have the ability to use that funding for the positive self-management program. So that's formula funding that they have access to. I do know that Florida does currently use that funding for HIV programs. So currently we're not getting any more funding on top of the discretionary funding we got in the $8.45 million, but that is for 3 years, and those 22 states have the ability to use those funds they get for the next 3 years for any of the 10 evidence-based programs. So on top of the 5 states already doing it, the other additional have the option to switch and add in the positive self-management program, and hopefully they will. So.
Okay. And so a follow-up question to that is, are there locations that FQHCs can receive training in those states that are currently funded so that they can provide a similar program in their state?
Yes. And some of the grantees in the states aren't our direct aging services network. Some are public health departments. Some are even federally qualified health centers. And so if that's why I included the link for the state contact, so you can actually see that some federally qualified health centers are already involved, as well as different grantees. Mm-hmm.
Okay. Excellent. Thank you so much. I don't know if we have any last-minute comments from any of our guests. We do not have any further questions in the queue, but any final thoughts or comments for our grantees?
Dr. Webb, one thing I'd like to mention, too, about the positive self-management program is the states have master trainers for the program who can train other individuals. So it's cost-effective to make contact with those master trainers in each of the 5 states if you'd like to be trained in positive self-management so that you can do it within your own community.
Excellent. Thank you so much.
Dr. Webb, this is Henry Pacheco from the National Hispanic Council on Aging. We just want to thank you and North American Management for inviting us to participate in this webinar and being in company of such wonderful and knowledgeable presenters.
Excellent. Thank you. And so I do want to let everyone know that today's webinar will be available on our website following this, the conclusion of the webinar. And we will have an audio version as well, sometime in the near future, a transcribed version as well. So please feel free to check back on our website at the www.healthandtheaging.org. If you have additional questions, feel free to contact any of us here on the staff at the National Center for Health and the Aging, and we will connect you with our presenters, and their resources will also be available on our website that you can link to at a further time. So everyone, thank you again. This is truly a very, very enlightening conversation and puts forth a very compelling case for why we really need to look at HIV/AIDS in the aging populations in our communities. So everyone, again, thank you for your participation today, and we look forward to continue to work with you.
Thank you very much, everybody. Thanks, Dr. Webb, for hosting this.
Absolutely.
Thank you so much.
Thank you. Bye-bye. Bye-bye.
Bye-bye.